Hello, my name is Erin Working, and I am a clinical educator for Ceribell Rapid Response EEG. Thank you for joining me to learn about non-convulsive seizures and this transformative technology that enables bedside seizure detection with real-time medication management for the nursing and bedside provider team. My clinical background is over 20 years of ICU, ED, and nursing supervisor experience at a large teaching hospital in Baltimore, Maryland. I am very excited to share our mission to optimize neurorecovery for all patients at academic and community hospitals alike. But first, let's take a quick moment to review the basic principles of conventional EEG and the disease state of non-convulsive status epilepticus. Electroencephalography is a non-invasive way to measure the voltage fluctuations from the ionic current between neurons. The electrophysiological monitoring system is applied by a technician that has advanced focus training with certifications. This is a snapshot of two differing patients' EEGs. Both images are from the Ceribell Rapid EEG montage. As they are labeled, the top is a normal pattern and the bottom is showing status epilepticus. Although interpreting EEG waveforms is outside of the nursing scope of practice, nurses are exceptional at identifying changes in patterns and trending data points over their shift. It is clear that the bottom pattern looks much different than the top. The lower waveform shows repetitive and rhythmic patterns of seizure. At an elementary level, one can see how these electrical discharges can create the physical manifestations of a tonic-clonic seizure. But that's easy to identify. We are here to talk about the seizures that aren't so easy to identify, non-convulsive seizures. So what is non-convulsive status epilepticus? Tenured nurses may have heard the term subclinical seizures, but they are both referring to the same disease state. Basically, it is as the name implies. Seizure discharges within the brain with minimal to no clinical manifestations. These patients present with altered mental status with fluctuating behavior. They may present with a GCS of 11 to 13. They may have eyelid twitching or lip smacking. They are difficult to diagnose due to the lack of awareness of the disease state and because you have to capture it on EEG. This is a classic representation of what non-convulsive seizure looks like from the end of the bed. Rhythmic, repetitive waveforms on EEG while your patient is lying motionless in bed. These patients are in all units of the hospital, not just the neuro ICU, the ED, the medical and cardiac ICUs, the trauma ICU, and rapid response patients. The importance of your hourly neuro exam cannot be overstated here. Nurses are the ones assessing these patients most frequently. Hourly in the ICU, but less frequently on the floors. But when you have a new finding, a subtle change, I ask you, what are you doing with this assessment? Are you calling your neurology team at 2 a.m.? Are you consulting a senior nurse in the unit for their opinion? Are you waiting until the team rounds in the morning? Are you traveling to CT yet again? To understand the unmet need, we must first look at the research and the landscape of the existing healthcare system. A hasty PubMed search shows us that the research into non-convulsive seizure has increased over the last 60 years. As I mentioned earlier, the only way to diagnose non-convulsive seizure is through an EEG. This is a technology that was not previously available to all facilities. The other change in critical care management is the change in the sedation policy. I grew up in the ICU when the patients were heavily sedated until metabolically ready for extubation. I had a great night. No one tried to extubate themselves, no one tried to crawl out of bed, no one moved themselves unless I repositioned them. My sheets were crisp and my lines were neatly labeled and not touching each other. There may have even been some haircuts and manicures performed during my younger days as an ICU nurse. Clearly, we ICU types have some OCD issues, but that's for another talk. But once we as a medical community stopped deeply sedating our patients, we became acutely aware that some of them progressed neurologically and some, sadly, did not. We are all familiar with the ICU liberation efforts and the delirium studies that preceded this initiative. The Neurocritical Care Society also took note. In 2012, almost a full decade ago, The Neurocritical Care Society stated that EEG should be initiated within 15 to 60 minutes if status is suspected and have definitive control over that disease state within 60 minutes. An amazing guideline for patient care, but incredibly difficult to meet for almost all hospitals. Most recently, in October of 2020, the AHA has now included EEG in its post-arrest algorithm, stating an EEG for the diagnosis of seizure should be promptly performed and interpreted, and then should be monitored frequently or continuously in comatose cardiac arrest patients after ROSC. I am anxiously awaiting the new research yet to come since the guideline has been established. The majority of seizures in the ICU are non-convulsive. In my 20 years of bedside experience, I can say I have never actually witnessed a convulsive seizure in the ICU. To understand which patients are at risk, I challenge you to review this list. I divide this list into two buckets, the first being patients following a convulsive seizure. Did you know that if the patient does not return to baseline within 10 minutes, you should consider non-convulsive seizure? 48% of these patients are sliding into that state. For my ED peers, think about your seizure patients that have received Ativan in the field. How long are we allowing them to be post-ictal? Or patients that were found down. How many seizure versus syncope patients have you triaged in the last week? Just something to reflect on. For my ICU peers, how many rapid response patients have been admitted to your unit at change of shift with an unknown time of last seen normal? Perhaps they have had a seizure, but it just wasn't witnessed. The second bucket is for all the remaining patients. These are patients that have known insult to the brain, tumor, trauma, subarachnoid and subdural bleeding, anoxic injury such as post-arrest or near drowning, infectious etiology, and ischemic stroke. Remember, these patients aren't just in the neuro ICU. They are in all departments within the hospital. The longer a seizure occurs, the worse a patient's outcome. This is not a difficult concept to grasp. What gets my attention on this slide is the duration of time being used as a benchmark. Look at the bottom axis, less than 10 hours, greater than 20 hours. Whose patient is that? It's all of our patients. All of our patients. We all know this adage, time is brain, time is brain, absolutely applicable to non-convulsive seizure. That being said, time to diagnosis and subsequent treatment is what matters most for the neuro-optimization of your patients. The longer a patient seizes, the worse their outcomes. The longer a patient seizes, the harder it is to treat. If observed or captured by EEG, your first-line agent of anti-epileptic medications is effective 80% on the first dose. The longer that seizure occurs without intervention, the less effective the first-line agent is. Subsequent doses and/or second agents are required to abate the seizure. This could lead to depressed respiratory drive and potential intubation. As nurses, we do what is best practice. Please hear me when I say that the information being presented to you are from the guidelines created from the Neurocritical Care Society and the American Heart Association. We as nurses and our bedside clinician partners are being charged with the prompt identification of non-convulsive seizure, prompt interpretation, and prompt treatment for at-risk patients. Despite guidelines, we are still unable to meet this need. This story is not just the story of your hospital. It is the story of most hospitals around the country. Lack of innovation in this space has left clinicians to continue treating empirically within a slow and cumbersome system. The unmet need is what has brought Ceribell Rapid Response EEG to the bedside for quick seizure triage and monitoring. So what is Ceribell? Cerebello is a three-part system. A single patient-use disposable headband that can be set up by any clinician and within 5 minutes have clinical quality EEG. There is a pocket-sized recorder that displays the EEG on the screen. There are two options for waveform interpretation. First, the brain stethoscope, which is an audible interpretation of seizure activity. Really great for spot checks by the nursing team. Second, software component called Clarity that is like an EEG tech monitoring the waveforms and constantly looking for patterns. It provides an instantaneous audible and visual alert at the bedside. The Cerebell recorder streams this information in real time over the hospital's medical device Wi-Fi to a HIPAA-compliant portal. This portal provides real-time remote viewing of the EEG data. The Ceribell device communicates directly to the portal. It does not communicate to your EMR system. Brain stethoscope is the first platform Ceribell introduced that allows for spot checking for seizure activity by the bedside team. If you can visualize the slide comparing a normal EEG to the EEG with seizure, this will make perfect sense. The normal brain had flat waveforms, similar to the flat sound you will hear. The seizing brain had repetitive, sharply contrasting waveforms, similar to the alarming sound that you may hear. Clarity is a machine-based learning algorithm that enhances the seizure detection ability for clinicians. It is continuously monitoring the EEG waveforms and displays a seizure burden percentage. It is the first FDA seizure burden trend for effective patient management. As you can see, a revolutionary critical care tool. Definitive medicine is predicated on deeper understanding of the disease state. Clarity will help the bedside team provide enhanced, definitive neurological care for your patients. Immediate triage provides immediate and definitive treatment. No longer are we overtreating patients based on clinical suspicion, or conversely, undertreating without the ability to diagnose non-convulsive seizure or reassess any interventions that may have been given. With real-time feedback of your patient's seizure burden, you will know when the treatment has stopped the seizure. By this point, you're probably saying, this all sounds logical to me. I have cared for these patients. I have seen overtreatment. I have certainly seen undertreatment. But nursing stands on best practice and evidence-based research. In June of last year, Critical Care Medicine published the Bedside clinical trial. It was a prospective, multi-center observational trial. We were trying to assess the impact that rapid EEG would have on clinical decision-making. What we found was that the average time between a stat EEG order and the start of the study was 4 hours. I repeat, 4 hours. We would never allow a patient to have a convulsive seizure for 4 hours. These are top academic centers with a hefty tool bag of resources. For just a moment, I would like you to think about the resources at your institution. What would you estimate is the ability of your team to meet this need? Again, this is the fault of the system and lack of innovation in this space, certainly not the personnel or individual resources. With Cerebell, the wait time was reduced to only 5 minutes. As stated earlier, Cerebell helps you deliver definitive treatment. These 3 clinical studies published in the Critical Care Medicine, Neurocritical Care, and the Journal of Neuroscience Nursing, respectively, all show that treatment decisions were improved 40% of the time with Cerebell, ruled out seizure, which avoided overtreatment, and in a staggering 18% diagnosed seizure when clinical suspicion was low. The Clarity algorithm is 100% sensitive to status epilepticus and 95% sensitive for ruling out seizure. This negative predictive value has been incredibly impactful for clinicians moving through the differential. Imagine you are in rounds with your bedside team. There is uncertainty about their neurological assessment. What should we do next? CAT scan, MRI, review the medication list again, consult neuro? Well, if this was the respiratory system, we might order an ABG or a VBG. If it was the cardiac system in question, we would quickly grab a 12-lead EKG. What is in your tool bag for quickly triaging the neurological system? The negative predictive value of Cerebell, coupled with the 100% sensitivity to status, provides this tool. For the patient with short seizures, calculated as 11 to 89% seizure burden, also provides valuable information. It is a spotlight on that patient that says, I am in need of advanced neurological care. It directs the team to reach out for further evaluation. Just as your 12-lead EKG might encourage a provider to seek counsel from a cardiologist instead of managing the patient alone. Should Cerebell identify a patient with non-convulsive seizure, the device will alarm audibly and visually as shown here in the red screen. The alarm will continue until a nurse acknowledges it. The 96% seizure burden seen on the middle image is recorded, and nursing will take next steps as we would with any critical value. We alert the responding clinician. Your responsibility is to elevate critical results up the chain of command. Seizure burden monitoring is no different. If medication is ordered, please continue as you normally would. Pull, scan, and administer the medication per the order. As you are monitoring the effect of your medication on the seizure burden screen, please use the orange flag tool on the lower left and select the medication given. This action helps provide information to the reading neurologist or epileptologist. There is not a camera on the device, and by flagging the medication, you are communicating with that team that an intervention was made. This can be performed by anyone on the team responding to the patient. No need to worry about the milligrams given or the exact time. Documenting in your EMR should take priority. The seizure burden is one data piece that goes into the decision-making process for our provider partners. Together, you are managing a medically complex patient. This matrix helps explain how your bedside neuroassessment fits into the patient's neurooptimization. It is critically important. If the clinical suspicion for seizure is high or low, it can help determine how providers should react. For example, if there is high clinical suspicion that your patient is having non-convulsive seizure and the seizure burden is 95%, then the neuro team should be stat paged. If the clinical suspicion is high, but the seizure burden is 5%, then the provider team should feel confident that because clarity has a strong negative predictive value, that they do not need to treat the patient, avoiding overtreatment. The information on the right of the matrix is from the Bedside trial, and you can see the real-world benefits of decreasing overtreatment and providing definitive treatment in real time. I'd like to share a case study from a tertiary center in Alabama. This patient had a high clinical suspicion from post-cardiac arrest, and nursing played an integral part in escalating treatment. As I said, this is an academic hospital with no continuous EEG services, and the patient is a 74-year-old man that was awake in the ER and following some commands, and then progressed to having a VFib arrest in the department, was resuscitated and put into the hypothermia protocol. He was heavily sedated and became hypotensive, went into acute renal failure. They did scan the patient's head on initial arrival and then sent him to the ICU. No MRI was able to be obtained because the patient had a pacemaker. Following the hypothermia protocol, Ceribell EEG was applied to the patient as they have no continuous EEG capabilities at this facility. Immediate alarm for seizures occurred at the bedside. There were no physical manifestations of seizure, not even an increase in heart rate. The nursing team alerted the responding clinician to the events, and the patient was treated immediately. The patient is clearly complex with multi-system organ failure. The quick actions of the nurse allowed for prompt treatment of seizure and the medication management that followed. This is a view of the seizure burden trend for the entire 11-hour patient study. Quick orientation to the screen, the x-axis is time and the y-axis is the seizure burden percentage. Less than 10% in the green is 30 seconds or less of seizure activity in a rolling 5-minute window. 11 to 89%, seen in the yellow and orange, indicates some seizure activity with 50% and over trending into the abundant segment. Greater than 90%, shown in red, indicates 4.5 out of 5 minutes of the patient having seizure activity. The Neurocritical Care Society defines status as 5 minutes of continuous seizure activity, and we at Cerebello are choosing to cast a slightly larger net at 4.5 minutes. As you can see, the notations for Ativan and Cerebrex on the top of the graph, those are entered by the nursing team. Please note the direct relationship between the medication administration and the decrease in the seizure burden graph. Monitoring interventions is squarely a nursing responsibility. We do not throw around medications without reassessing their impact on the patient's clinical picture. It is very exciting to be able to monitor their seizure burden in real time with this medication management tool. Putting it all together, this is what your nursing assessment and advocacy for non-convulsive seizure triage with the Ceribell Rapid EEG culminates to. At 6 minutes reading speed, you are watching the actual EEG waveforms scroll across. Underneath the waveforms is the seizure burden trend. Finally, the reading team can hover over your medication annotations to discover what medications were administered and observe their impact on the seizure burden and EEG waveforms. As healthcare providers, we can never know it all, but what we can do is know where our resources are. Please visit our website at www.cerebell.com for additional information. On our splash page, you can see choices to review the unmet need and challenges of the existing system, a deeper dive into the headband and recorder, research, and about the company itself. There are also recorded user experiences from varied disciplines: nursing, intensivists, neurologists, and epileptologists. Very interesting perspectives on the real-world application of rapid EEG. You can also request a free demo using the orange button. To the right of the orange button, you will see EEG University. When you click that, you can select allied health professionals from the drop-down menu over here on the guide to your learning experience. There are also upcoming events and webinars that you can access live. We would love to have you join us. Thank you for your time today. I hope you enjoyed learning about non-convulsive seizure in the critically ill patient and the advent of EEG crossing into the triage space. Cerebell, providing instant bedside seizure diagnosis and real-time medication management for the neuro-optimization of your patients. Thank you so much and have a great day.